Hi, everyone. Thank you so much for joining us tonight. My name is Kim Watkins. I'm the Director of Advocacy at the Melanoma Research Foundation, and I am joined tonight on our Rural Health webinar, Getting Screened in Rural America, Our Drive for Rural Health Equity, by Justin Markowski, Dr. Robert Brodell, and hopefully joining us soon will be Dr. Jane Bolin. So welcome to our panelists. Thank you so much for joining us. A bit of housekeeping before we get into our introductions and the panel itself. This is a recorded webinar. It will be available on the MRF social media going forward if you can't join us live tonight. And you can find those at melanoma.org. Additionally, if you have questions for our panelists, please put them in the chat. We will have some time towards the end of our programmed questions to get to your questions and hopefully answer them if there is time available. So without further ado, I'd like to introduce our wonderful panelists tonight. I'm joined by Justin Markowski. He's currently a PhD candidate at the Yale School of Public Health. His research focuses on evaluating and improving the healthcare safety net, oriented toward identifying actionable, responsive policy solutions to the current challenges faced by care delivery organizations and the communities they serve. Most recently, Justin led a study published in the Health Affairs Journal that found health professional shortage areas to have no significant impact on mortality or physician density, and we will hear more about that in a moment. I'm also joined by Dr. Robert Brodell. He's a tenured professor and chair of the Department of Pathology, past founding chair of the Department of Dermatology, and Billy S. Guyton, MD, distinguished professor at the University of Mississippi Medical Center. He spent 27 years in solo private practice in his hometown of Warren, Ohio, before moving to Jackson, Mississippi to work with a team of dermatologists to care for patients, read skin pathology cases, and start a residency training program in 2012. And lastly, Dr. Jane Bolin is the Associate Dean for Research at the Texas A&M School of Nursing and a professor at the Texas A&M School of Public Health. Dr. Bolin is an attorney, and she teaches health law and ethics and human resource management for graduate students. She also serves as Deputy Director of the Texas A&M Southwest Rural Health Research Center. And Dr. Bolin's research focus is diabetes and chronic diseases, cancer prevention and screening, rural health disparities in health law, regulation, and ethics. So welcome, panelists. Thank you so much for joining us tonight.
Glad to be here.
Thank you for having us.
Wonderful. Well, to set the stage for everyone joining in, I think we all have our own ideas of what rural America is or who rural patients are. But Dr. Brodell, since you were a clinician in a rural setting, can you give us an idea of who rural patients are? How do we define this community? And most importantly, why are they at risk of melanoma?
Sure. Rural patients are perhaps easy to look at and know who they are, but perhaps hard to define. The federal government has definitive ways of determining who is in a rural area of the country because they have certain programs they support that relate to rural communities. But I guess what I would suggest in the way of dermatologists is that think about how hard it was for many in this audience to see a dermatologist. And then imagine if you lived in a county with 0 dermatologists. And in fact, 88% of rural counties have no dermatologist. So there are certainly people in this audience that know that if you had trouble getting into a dermatologist in your little city or town, imagine what it would be if you were in a rural county.
And why are they necessarily at risk of melanoma? Are there certain, occupations that tend to happen in higher rates in rural settings, or is there something else?
Right, it's kind of a double whammy. Not only do they have difficulty accessing a dermatologist, if you live in the country, it's more likely you're a farmer or you work or play outside and they, because of the sun exposure, have an increased risk of malignant melanoma.
I see. And so you alluded to there's struggles for anyone to access a dermatologist, but specifically for rural patients, what are some? I can imagine one's geography, but what are some of the other immediate barriers they face in receiving care, and even some of the ancillary costs or other risk factors that might come into play?
Sure. Well, let's talk about Mississippi.
Okay.
Mississippi is a rural state. We have half the number of dermatologists as the average state. And then look at the Delta in Mississippi. The Delta in Mississippi has a number of counties, 5, 6, 7 counties, in a 50-mile by 100-mile area with no dermatologists. It also happens to be the poorest area of the state. So now imagine living there. How do you come up with gas money to go to the university, 2.5 hours away? Whose car do you borrow? If you make an appointment, is that friend that was going to bring you available on that day or is he going to call and say, oops, my car broke down? So there are all kinds of problems that lead to an interesting phenomenon of people that make an appointment from the Delta at the University of Mississippi. Only 14% actually make it to their appointment. And who knows who's out there that didn't get the appointment at all.
I see. And Justin, I can imagine some of your research has probably illuminated some of those issues too.
Definitely. I mean, this is a problem exemplified by some areas very targeted, such as the Mississippi Delta, but it's really a nationwide phenomenon, just to underscore that point. We see that there are over 40 million people living in underserved communities, in rural communities, that just don't have access to physicians and don't have access to basic health care, let alone the specialized care required for many melanoma-related cancers. So this is a real phenomenon that affects tens of millions of people nationwide, really.
So let's set the stage here. You're a person living in a rural community. You finally, after maybe months or even in some cases years, of having something that should have been looked at earlier, looked at. You're now in your dermatologist's office. You have found a suspicious lesion. How does that shape their outcome, their care from that moment forward? What options do those rural patients have who are maybe on Medicaid, or they're maybe not necessarily uninsured, but they're underinsured, they have high deductible plans, et cetera? What happens when treatment becomes unaffordable for that population? And I'll open that up to whoever would like to start, really. I feel like there's probably a lot of meat in here.
Yeah, it's a critical problem. So at the University of Mississippi, we have social workers that work with people to try to determine what, if they meet a certain income level that would allow them to get Medicaid coverage. We also have a policy at my university that there are 3 categories of people we see under all circumstances. Those are people with cancer, women that are pregnant, and children. So we have our own sort of safety net that would cover that person with malignant melanoma. The unfortunate thing is, as you sort of set up, that person that has trouble accessing care, that watch their malignant melanoma get larger and larger, it's also deeper and deeper, more likely to have spread when excision that would have been curative.
So I think that is probably a very, natural segue to understanding what some of those proposed solutions are to address this issue. Justin, you've done, your research is kind of on this. Can you talk a bit about what's been proposed, and how that system has shaped how we look at fixing this problem?
Sure. So we took a look at the hallmark of our federal approach, which is to incentivize health professionals, physicians, nurse practitioners, and PAs to work in underserved areas, which by and large cover most of the rural communities in the US. However, we found that these programs have very little evidence of actual success how do I say this, reallocating the physician workforce. That instead, we find that these underserved areas remain underserved. So despite 50, 60 years of policy attention, many shortage areas are still experiencing a profound shortage. And this is not only just primary care providers, it's specialists of all kinds. And as we just talked about, you can imagine that the fact that this is the core of our federal approach, and it's coming up short. So we really need to think outside of the box to help develop solutions collectively and really engage with policymakers to put our footprint on this issue and help resolve these shortages. So one example of which is the using telemedicine, which is something that we really can talk about in rural settings, of course. This is one piece of the puzzle, maybe providing better access to dermatologists is via new advances in technology. There's a national effort to roll out broadband internet to make that possible. So there's a lot of different policy features in terms of technology, but we can also think really carefully about using skilled nurse practitioners and physician assistants to help assist in that process as well, to be able to provide and expand access to primary care, and again, shrink the time between each phase and the recognition process from screening to diagnosis to treatment, and really thinking about how we can use the entire healthcare workforce to expand access. What Dr. Brodell mentioned about using social workers to help effectively work as financial counselors is one key piece, and it can, because it removes the financial barrier. And using a nurse or a nurse practitioner as another screening piece could be removing a primary care barrier. And by thinking about the different barriers and what we can do to break down them at each step along the way is part of the process. So we can think holistically, but by segmenting the problem, we can think really carefully.
So Justin, what I hear you saying is that changing reimbursement structures for providers alone isn't enough to incentivize providers to set up shop in rural communities.
It's unlikely to be the case. I mean, I grew up in a small town and we didn't have a physician or anyone there, but there also, just from a very practical standpoint, there wasn't necessarily a place for them to operate in many ways. There was not an existing practice that was ready to take in a primary care physician. So instead, it took many years for the town to literally rezone part of the town to allow, and then to submit an application to the Department of Public Health. So there's all these administrative pieces embedded there, where if you don't have the infrastructure, you can incentivize folks with as much money as you want, and it's unlikely to actually move the needle, which, just to be clear, I'm sorry, go ahead. Yeah, of course.
Well, and I might add that when I started in my solo private practice in rural northeastern Ohio, that was 35, 40 years ago, whatever it was. When I did that, 80% of dermatologists went into solo private practice. That number is now 2%.
Oh, yeah.
So if you're talking about a rural county, what is the chance that you have somebody going to set up a solo private practice when the pool you're drawing from is 2% of the graduates? It's more difficult to be in a solo private practice nowadays.
Oh, yeah.
Go ahead.
Especially because, to your point about the reimbursement structure, it's so complicated. It becomes like financially, from a business sense, it's so difficult to convince folks to want to go into private practice because billing insurance is complicated. Getting folks enrolled in insurance is complicated. And just the calculus has fundamentally shifted,
Yeah, the
where
24 regulatory agencies that impact your practice make it a daunting task for somebody graduating from a dermatology program.
Of hiring the staff, the office staff, the billing specialists, people, having the, computers that are epic.
That's
Yeah,
$100,000 for the computer system.
exactly. And so, Dr. Burdell, you've kind of seen this from, to use your words, you've been a clinician for a very long time. And so you've seen some of that shift in medicine over, the past 30 years. And I'll stop at 30 for you. But what has that looked like? We've spoken to some of those complicating factors that have only made practicing medicine more complicated. And now you're on the academic side. So I'd be really curious what you're hearing from your students, what you saw yourself, at the beginning of your career versus when you left private practice, and how that shift occurred to on a personal level.
Sure. Well, what I've seen is that there are a couple of truisms that were true before and are true now that help us think of a way forward. One of those things is that if you take a medical student who grew up in rural America and you plant them back in their hometown, they're likely to stay. It can work. So one of the things we did in Mississippi was we developed a rural residency training track. So one of 5 residents each year is going to spend 3 months of each of their 3 years in our rural academic office, 90 miles from Jackson in the middle of nowhere. They're working with somebody who loves rural America. They're going pheasant hunting in the right season. They're going fishing in the right season. When the water floods his farm, they go out and break up the beaver dam with him. They understand you can live somewhere where your doors are unlocked. So that's part of it, is seeing that you can enjoy and be successful as a rural doctor. But the thing that we did that's different than a program just like ours that failed is we take people into this program who are from rural Mississippi, or in a few cases, we've taken somebody from rural Kentucky and some other rural states to plant some people a little further away from us. We've had virtually 100% of our people honor their commitment, which is really a handshake commitment, to go back for 3 years to that area. And it's been exciting to see this program work by just applying one little tweak of taking those people from rural areas.
Do they come to you when they express an interest, and so they're proactive, or do you have a recruitment process in place where you're identifying them?
We go after them. We
Ah,
go to the
tell me more.
dermatology interest group, the first year medical students. Where are you from? And then we nurture those people from rural areas that may actually, in some cases, they're behind a little bit for certain reasons. We nurture them, write papers with them, anything we can do to make them successful. And we also have the only exemption to the all-in provision of the match. The match is a thing that says in a given program, if you take one person, you have to take all your residents in the match. But they gave us an exemption for this rural person because we explained to them we're investing in this person. We don't want them to make a horrible decision and go to Harvard to train or something like that. When we've made a commitment, they make a commitment, and in the fall before the match, they sign up, drop out of the match, and that's been highly effective for us.
I see. And just to take a brief pause, Dr. Bolin had some technical difficulties earlier, but she has joined us now. So welcome, Dr. Bolin.
Okay.
Just to catch you up a little bit, we were kind of setting the stage with some of the policy proposals that have been offered to alleviate the workforce shortage in rural communities. Justin has spoken to, it's not just about reimbursement, it needs a whole ecosystem around it. Dr. Burdell has spoken a bit to how his program in Mississippi is actively working to identify students who would have a high likelihood of practicing in a rural setting. And I would like to give Dr. Boleyn a chance to respond here, but Dr. Burdell, very briefly, have you tracked the success of the program? Do those students who you recruited stay beyond their 3 years?
Yeah, so we only have a few of them that are more than 3 years, so I can't really answer that question, but these people are in their hometown.
Yeah.
And they're happy and they're successful financially. And there's no reason for me to think that this program is going to suddenly collapse because everybody moves to New York City to go to Broadway shows every night.
I've seen, to piggyback on this, I've seen similar programs in Colorado that focus on an education first type initiative. So these are long-term problems. These are entrenched disparities between urban and rural areas. And by taking this long-term approach, by saying we're going to cultivate education in these rural communities, we're going to raise up the community by providing pathways to education. It's remarkable. I've seen it in Colorado, I've seen it in Kansas, and this beautiful example from Mississippi as well. It is one way to think about it, but it seems to be really powerful when it works.
And Dr. Boleyn, I'd love to give you a chance to respond to some of the policy.
Sure. First, my apologies and thank you all for inviting me to join. I represent the Southwest Rural Health Research Foundation or Research Center at Texas A&M University. We've studied the problem of urban disparities now for over 30 years. And what we're talking about is access to care at its core, and access to care in all areas of medicine and healthcare is a really big problem in rural America. And then you compound that with some parts of the country, and in particular some states that haven't expanded Medicaid, as well as may not have the wherewithal and the resources and infrastructure to apply for federal grant and supplements to encourage rural providers, rural practitioners to practice in rural areas. It does, in addition, compound the problem. So we know that access to care in terms of dermatology and all other areas is actually going down. It's becoming, let me rephrase that, it's becoming a much more serious issue. And what Dr. Brodell and Justin Markowski alluded to are, I concur with totally. And again, nurse practitioners are an alternative, and there is, our specialties within the area of nurse practitioner care that do specialize not only in primary care, but also areas of dermatology that would complement the rural healthcare provider, as well as telemedicine and referring to teledermatology, which was found to be quite successful during the pandemic. So again, I concur with everything they've stated so far. It is a significant issue.
Well, thank you for that. And I think, this conversation highlights there's no silver bullet here, right? It takes a whole lot of things going right to actually start to move the needle for a population that we can all agree is at increased risk of this absolutely horrific disease. And so what are some of those realistic solutions? And, are they significant enough? Where do we even start to fix this problem? And, we can just, whoever wants to take this one first, you are welcome. I think everybody's going to have some input here.
That one is right in my wheelhouse. So one thing is there are 13 states that do not have dermatology residency training programs. We didn't have one in Mississippi till 12 years ago, when I was asked to come develop a team of people that could train residents in our great state. So it turns out 12 years later, we now see 60,000 patients a year.
Wow.
60,000 in a rural state. In addition to that, our residents that we've graduated, added to the faculty that I've recruited, are 42% of all the dermatologists in the state of Mississippi in 12 years.
Wow.
So any of those 13 states out there that have a medical school that don't have a dermatology residency training program, call me. Then I met with my dean, and the dean said, Dr. Brodell, you're here not just to take care of the people of Jackson, you're responsible for all the people of Mississippi. Well, I took that as my marching orders. So we do in Mississippi what I call all of the above. Anything that anyone is doing in any state to deliver rural access to care, we do it in Mississippi. So we do teledermatology in a special way. We do it through primary care doctors. We want to be educating primary care doctors with every patient they send us so they can do more of their own dermatology. We do Project Echo, where you train once a month over lunchtime primary care doctors all over Mississippi, trying to teach the 10 or 20 most common skin conditions using their own patients. They send images in of patients right in their practice at that time that they need help with, sort of like a telederm consult. And then we discuss that, and we often have 60 or 80 primary care doctors from rural Mississippi on the call. We have a free clinic in the Delta. So we have 16 faculty. Once a year or so, you volunteer to go to the Delta. We work out of a nurse practitioner primary care clinic in the Delta, and that one day is dermatology day. So we help the nurse practitioners learn dermatology, but we're also caring for patients. So then with our rural dermatology track, seeding more specialists around the state, these kinds of things definitely work. You just have to have the will to try them. And actually, there's a secret. You can make money doing these things. You just have to do it. It's not like you have to be Mother Teresa to embark on these kinds of programs.
No, I think that's a really important statement to make, particularly if we have any providers or even other medical societies or representatives listening in. Unless you are independently wealthy, most people need to work to earn a living. And I don't think there's anything wrong with ensuring that the people who are working in rural communities are compensated for their time, because it's, last I checked, it is not free to go to medical school for most people. And Dr. Brodell, to your point earlier, especially when you're recruiting from rural communities, you might be recruiting a student who is first generation. They're the first in their family to go to college, let alone something like medical school. So for them, the debt burden can be astronomical, and ensuring they have a path to financial solvency for themselves and their families is critical, I think.
Totally agree.
We kind of started this question with, what are those realistic policy solutions? And, Dr. Bolin and Justin, you're both kind of very much in the, policy, my world, policy and advocacy space. So I would love to hear your take on some of, from local all the way to federal, what you think are some realistic solutions too, that kind of complement the, boots on the ground work that Dr. Brodell and institutions like his are doing.
I believe that it would be really beneficial for partnering organizations that can get the message out, like the National Rural Health Association, just like it did with rural emergency care, can begin to republish this need at the highest levels in federal Congress, as well as to HRSA, the Federal Office of Rural Health Policy can do some targeting funding mechanisms to get medical schools, advanced practice nursing programs interested in this area to make it, to launch it, to provide that initial kick. So partnering organizations, funding from the highest levels will get to help launch the pilots that will make it sort of like cancer screening, as we're focused on in this webinar, to put cancer programs, put this forefront on their radar with some jumpstart funding from national funders would also be an excellent approach. Justin?
Definitely 100% agree with that, and agree with what Dr. Brodell said as well. I spend a lot of my time thinking about community health centers as well as a way to leverage the existing infrastructure that's already fairly broad, but can be expanded into more rural and frontier type communities. There's already some policy in place where there is this safety net system existing. And while that's near and dear to my heart, I do believe that by expanding some of these safety net, where these safety net clinics are, can be one mechanism to ease that transition that we talked about earlier about the challenges with folks moving into rural communities without infrastructure supports. And I think by using existing organizations and trying to incentivize them to grow further and deeper into rural communities, you can really build out and grow an organic network of safety net providers by using the existing systems that are already at the border, so to speak. But you can really create something more like a hub and spoke model where you have these clinics that support and financially have sustainable financial models by allowing them to expand and place clinics in the Delta, for example, or in rural Montana, where they have the ability to support an independent nurse practitioner, an independent provider of some type, because they're connected to a larger network. So it builds in both the need to support our providers to make sure that they're not just out in the middle of nowhere with no support, but it also justifies that process at the same time. So I think that that's something I think about, but also we could, I mean, of course, more money for this problem is always, like, there's this question about what are we advocating for? You could always advocate to expand our federal spending on this topic, but I would like to see, and I would recommend pushing for smarter solutions so that we're not just throwing money at the same problems. If what I've seen is true, then despite the past 50, 60 years of effort, we're still facing these challenges. So our solutions have been, by and large, insufficient to be able to move the needle in a substantial way. So now's the time where I would actually challenge all of you to, as advocates who have one foot on the ground, to be able to see, well, let's try this, let's try that. Now's the time for creative solutions, really. And I'm not going to sit here and say that I have all the solutions, because I don't, of course. But I definitely would say that you may have a great idea, and whatever that is, try it, go for it. There's plenty of, to the points earlier, there's plenty of ways to make these solutions sustainable. It just requires a little bit of willpower to make it happen. So you all have the ideas.
Well, and I'll share that last year our advocates went to the Hill and they advocated for the Connect for Health Act, which is a telehealth bill that would allow some of those protections, provisions that people, expanded telehealth access for everyone all over the country. It would allow those to go beyond just the public health emergency. So it would create a pathway to allow you to take a telehealth visit from your home, or, you don't necessarily have to live in a rural community to access telehealth and have it covered. As we like to say, by Medicare or, your insurance company. That said, to our point earlier, just having the policy, the reimbursement set in place for telehealth, for example. It doesn't fix the broadband issue. You have to be, I think we need policymakers to think holistically and to be able to walk and chew gum at the same time, because you're not going to see real solutions or real movement on not just, melanoma, but any skin cancer screening, any health disparity, until we start thinking about the problem in a much larger context. It's not just, we're presenting this issue from the dermatology perspective, from the melanoma perspective. This is an issue that touches obstetrics, it touches primary care, it touches, any other kind of specialty under the sun. This is just our little piece of it. But it's a big and important piece, and we are proud to have advocates from all over the country joining us at our Hill Day on March 5th, where we go to the Capitol Hill, we talk to lawmakers about these issues, and our patients tie their stories, their own care journey or their loved one's care journey, to the outcomes, to the policy issues we are talking about here tonight. And so this is a really great time, I think, to take a deeper dive on what is really driving some of these problems. And very appreciative to all of you for joining us tonight. Kind of, closing us out here with the scheduled, or the, I guess, planned questions. What is the most important takeaway that all of you want patients and the wider community to learn from this webinar? This is obviously the first one, and we do hope to continue this conversation through other facets of the melanoma journey. And, we're largely talking about cutaneous melanoma here. We also represent rare melanoma patients, and that is a whole other layer when it comes to seeking solutions. But for the cutaneous community, what is the most important takeaway to you for having this conversation, for being here tonight? And I guess I'll start with Dr. Bolin for this one.
Sure. Well, I think the most important takeaway is that as the larger audience understands that access to care is a significant issue in rural America. So number one, we need to be proactive. Individuals need to be proactive about their own care, understand what the risks are in their particular state or where they particularly live in terms of the risk of melanoma or risk of skin cancer and in general. But then be aware that if it is diagnosed and you do need care or surgery of some sort, and it's daunting to try to get into a medical center, that there are so many organizations out there that are willing to help individuals with cost, with transportation, with getting in and out of big medical centers, or even access, once you get set up, to a regional medical center, a satellite campus, if you will. So there is assistance out there, and I really like Justin's suggestion about community health centers, and also don't forget FQHCs in that larger context, that they will help. Sometimes the directors of programs have to go hat in hand out to other surgeons and to other programs and say, can you help this patient out? And we'll contact foundations to try to help take care of the cost, but we all want to work at this and provide care to patients who otherwise couldn't afford it. Thank you.
I'd like to just mention the American Cancer Society Hope Lodge, totally free lodging available in, I think, 30 places around the country. So if you get there, you can stay there till your treatment is finished, and then on your way home, and totally free service.
Right.
That's wonderful. And the MRF, we also have patient resources available. We have an Ask the Nurse hotline. So, if anyone watching tonight does need resources, please reach out to us as well. We're happy to help wherever we can, or connect you with other organizations.
Point as well about financing. Many hospitals have charity care options as well. Don't be afraid to add to help patients with whom you're working, to ask about the charity care. I've seen bills over $100,000 just go get wiped away as part of that from hospitals. So really, I mean, I know it feels very odd sometimes and some hospitals make it a little more difficult to receive the charity care than others, but definitely help folks ask that, because again, I've seen large bills be just forgiven outright. So there are ways to do that. There are ways for sure.
And Dr. Brodell, what would your, kind of key takeaway be? I know you mentioned the lodging assistance that American Cancer Society provides, but from your own purview.
I guess the key thing I would say is that I'm trying every way I know how to get the message out there that there are solutions that work that could be applied right now for dermatology in the United States of America. So we have 5 programs, one at UAB, one at Penn State, one at St. Louis University. Who am I forgetting? There are programs that are doing our rural residency track right now, always with slightly different things than what we did to meet their special needs that make a difference. And so during COVID, my faculty wrote a book on rural access to care. And so in that book, we have 18 chapters that talk about different things that you can do to help solve this problem, including many of the things we've already talked about. So I'm trying to get the message out there. This is not the time to wait for the federal government to do something. This is time for all of us to act now. And it's certainly something that's critically important because, as you've said, things are not just stable, they're getting worse. So the status quo is not satisfactory.
And I think, to your point, the federal government, they're certainly an important stakeholder in this conversation, but far from the only one. Local governments can shape just as much policy sometimes, or state governments. And so there really does need to be a comprehensive approach to any policy solutions. We do have a few audience questions, and I believe we are okay for time. So I'm going to start reading some of these off for you. Let's see. The first one is, how can we advocate for better access for these patients, including those that might not be able to use telehealth because of lack of broadband or cell access, for example?
Yeah, so one issue is that live telehealth was not as successful during COVID. Store and forward telehealth took a giant leap forward. So
Okay.
what I would say is, see if you can find your primary care doctor that might be interested in jumping into our Project Echo. My name is Robert Brodell. You'll find me on the internet somewhere, and send me an email. I'd be glad to hook that primary care doctor into Project Echo, or perhaps hook them into our or another state's store and forward program so that they can see a patient in the practice, know they need help, but not have to send them 200 miles. Have somebody help them take care of that patient in their practice.
Can you break down that store and forward just a little bit more in case someone's not familiar with the terminology?
Yeah, sorry, I did jump into that a little quickly. You can imagine a circumstance where your doctor, your dermatologist is talking to you in your home. That's live synchronous teledermatology. Well, that is fraught with all kinds of problems. It turns out that there are a million technical problems that shouldn't exist, but they do. The minute the doctor sits down, the patient clicks off. The patient, you can't see him in the dark house. You say, walk outside, and they lose the connection to their, local system, and millions of other things that seem to make it that every patient is a problem. Now imagine you're with your primary care doctor. They take a picture of you, a picture of the front sheet with your billing information. They write what their question is for the doctor, and they send it to our National Telehealth Center. And one day they put that into Epic. Within the next 24 hours, we get back to that doctor with an answer to their question. About 80% of the time, we help the doctor take care of the patient there. About 20% of the time, we get them into our rapid access clinics so we can help. Maybe a biopsy is needed, something that can't be done through telehealth. So there are ways to make that very effective.
My thinking in accordance with the two other panelists is they're spot on. We can come at this from different directions, and some of the examples I've used in rural healthcare are the mobile mammography programs, whereas part of the teaching function of a academic medical center, we send out our mobile clinics, and as part of our screening clinics, we do paps, breasts, and liver, as well as we can draw blood, do some basic pathology, but we get the mammogram, we send it in to participating and cooperating radiologists. They don't have to be on site, but as part of our teaching function, we're providing that service out to rural communities. It's paid for by the state. It provides a multitude of benefits, both to the institution, to the programs, as well as to rural providers. Or I've seen it with diabetes. You know, you take a diabetic retinopathy picture, it's immediately sent in, HIPAA compliant to an ophthalmologist so they can read it. Now, granted, there are some things we lose as we would in terms of looking and inspecting skin or skin lesions like smell or, just other things. But all of these are solutions that can be combined and approached creatively by those with the will to tackle the problem.
And by the way, patient education that your foundation is very big on is a critical part of this, because the rural patient that knows the ABCDs, that if you have a pigmented lesion that's asymmetric, if you cut it in half, one side's different than the other. It has an irregular border or notches in the border. There are different colors, the C, different colors in the same lesion, brown, black, red, white from regression from the body attacking the melanoma. And D, large diameter, bigger than a pencil eraser. If someone recognizes that, the patient in a rural area, they need to reach out and they need to do what needs to be done to get to see a doctor. And then I want to mention the E, evolution or changing. So the single most important thing for early melanoma is to make patients know if you have a mole that's growing, changing, gets red, bleeds, hurts, drains, any change, you need to get a doctor or nurse practitioner to see that so that you have the opportunity to reach out and access the care that you most certainly need.
I think that's an absolutely critical point is, we have to empower patients to be their own best advocate, their first set of eyes, because we're all navigating the same flawed healthcare system, and some with more resources than others. And so it's really imperative that patients be informed, that they're aware of things like wearing sunscreen. The best sunscreen is the one you'll use. Wear it every day, not just not just in the summer. And so there are a lot of reasons and a lot of opportunities for us to reach patients before they get to the point where they're facing a malignant melanoma. And that's certainly our goal here at the MRF, to focus on prevention, but to also support patients as they navigate melanoma completely.
And to clarify for everybody that heard this, I focused on early detection. Kim focused on prevention. Both are critically important.
Yep, absolutely. If we can't prevent, prevention is preferable, of course, but if we can't prevent, we want to detect early, when they're most treatable and have the best chance of a positive outcome for the patient. So why should everyone care about rural health equity, even if you're not from a rural area? how does this affect somebody who, might be an advocate coming from LA, for example?
So I'll start there. It turns out that if you have a melanoma that's metastatic, that sent seeds around your body, there are a number of treatments for that, including some new biologic treatments that are miraculous. The thing that allowed Jimmy Carter to live 12 years after having metastatic melanoma, biologic medications that cost $1 million a year. So truly, an ounce of prevention is worth a pound of that kind of expensive cure. But yeah, if I have metastatic melanoma, I want the latest treatment. But yeah, everybody needs to realize those facts.
And Justin, I bet, and Dr. Berlin too, can y'all elaborate on, as we have more patients accessing care at higher and higher points of entry from a cost perspective to the system, what does that do to everybody?
I mean, that's definitely a critical part of this, without a doubt. Equity in my world affects all of us, means that it's affecting all of us. It means someone's going without because someone may be going with. And I think that in order to build a better, more fair, just healthcare system, we really need to grapple with these fundamental questions about who's getting care, where they're getting care, and how much care is being provided. Because so often in our system, folks are getting left behind, folks are getting forgotten. And we need to think through and truly advocate because for a better, more equitable system. And especially now, though, I think the pandemic, if it did one good thing, it brought to the forefront these challenges that we're talking about today. And we have some solutions to the challenges that we also talked about today. But now we have this beautiful little window where I think policymakers are interested, where everyone's being activated, and we have solutions. I mean, we're getting the triple threat right now. So now is the time for us to really tackle these issues and for you all to go to Congress to really bring these issues, tell your stories, and stick it to them almost, because in doing so, we can not only highlight the issues, but we can bring along the solutions and actually make some real change here. So now is the time. The window's open. It's just time for us to walk through it.
And Dr. Berlin, I guess you get the last word here. We are right at time.
Oh no.
I agree with everything that's been said. These are all big issues, but there are solutions to addressing rural health equity.
Well, and I guess we will leave it there for tonight. Thank you all for joining us. It has been an absolute pleasure, and I hope that all of you who are viewing this with us have walked away with a deeper understanding of some of the challenges facing rural patients, why when we go to the Hill and we talk about things like telehealth, we're not just serving one population here. We are working towards solutions that fit everyone. A rising tide lifts all ships, as my South Carolina Nana used to say.
Here, here.
Yep. And so those of you who are viewing, there is a post-event survey. Please, you'll receive that in your email. Please take it. This will be available on the MRF social media channels, as I stated at the beginning of our webinar. And please be on the lookout for future webinars on rural health equity, because as we said earlier, this is the first webinar. It's the first kind of touch point. It felt like screening was a good place to start as we take a look at the equity issues facing rural melanoma patients. So thank you to Dr. Burdell, Dr. Berlin, and Justin Markowski. We have learned so much, and I can't wait to go to the Hill and put all of this into practice.
Thanks for having us. Everybody have a great night.
Thank you.
Thank
all.
you. Take care.